Hey, good evening.
You're muted, Enid.
Sorry. Yeah, I realized. Okay. Hi, I'm Enid Eckstein. I'm your host for this evening. I want to welcome people to this forum, jointly sponsored by Progressive Mass and Mass Care, which examines the Steward crisis and the future of healthcare. I'm going to say a little bit about our sponsors, and then I'm going to go through a little bit of history and an explanation of our forum tonight and talk specifically about the format, etc. So please, people, please remain muted. There will be opportunities to put questions in the chat. But tonight, I'm part of Jamaica Plain Progressives, which is part of Progressive Mass. And Progressive Mass is a statewide, member-driven grassroots organization committed to fighting for a vision of shared prosperity, racial and social justice, good government, and environmental sustainability in Massachusetts. We have some 20 chapters across the state, and our chapters are engaged in local campaigns, statewide campaigns to support a statewide agenda for progressive change in Massachusetts. And we, periodically schedule forums that attempt to take on some very serious topics, which obviously tonight the Steward crisis is a major, issue facing many of us in the state. And just by evidence, we had over 200 people sign up for tonight's forum. So I want to briefly introduce Kimberly Connors, who's the director of Mass Care, to talk a little bit about Mass Care, and then we'll move right into the forum. So Kimberly.
Thank you, Enid. I appreciate that. Hi, everyone. I am Kimberly Connors, the executive director of Mass Care, the Massachusetts Campaign for Single-Payer Healthcare. We are a coalition of over 100 organizations, including groups representing the elderly, low-income people, labor unions, teachers, nurses, social workers, doctors, interns, women, immigrants, and municipalities who all actively support establishing single payer in Massachusetts. We work with legislators on the Medicare for All Act that will establish the Massachusetts Healthcare Trust, a single payer healthcare system that will assure all residents have access to comprehensive, quality, and equitable healthcare, publicly financed and free from out-of-pocket costs. We are actively fighting to keep hospitals in communities. We know that our voice is being heard as we have provided some of the legal underpinnings that convince the state to act to save St. Elizabeth's by eminent domain. And I just want to say very briefly that today's official press conference belies the fact that Ralph De La Torre is not just a symptom. He is just a symptom of systemic failures. There is no such thing as a healthcare marketplace, and people's healthcare should never be treated as a commodity. Thank you very much for allowing us to be the co-sponsor of tonight.
Okay, and thank you, Kimberly, because I feel you're helping to set the context. So for many people who are on this call, they may be familiar with Steward, but not everybody. So I'm going to just tell you a little bit of background and why we picked doing this forum tonight. So the Steward system, as of a year and a half ago, was serving over 350,000 patients in Massachusetts, and it owns 11 separate hospitals in the state. Yet, as we know, this system has struggled for many years. And now, today, whether you picked up the paper, you can't help but read the news: bankruptcy, corporate greed, private equity, hospital closings, possible criminal charges, Globe Spotlight team, and the whole issue of eminent domain are now part of the story that is being written as we speak. Closings and transfer of these hospitals will have major repercussions in our communities, not only for the healthcare community, but for thousands of workers who provided care and for the patients who need these services. Patients served by Kearney and Neshoba are left with hospitals shuttered just in a matter of days without a nearby healthcare provider. Kearney Hospital closing just exacerbates existing health inequities in our city. And the closing of Kearney also means the loss of over 50 needed psych beds, which is going to create a crisis. So one question we'll be asking is how many will needlessly suffer due to a lack of immediate access to a facility? And what will be the ripple effect of closing all these hospitals on an already stressed healthcare system? Now, in terms of the form, I want to just say, how did we get here? Well, we thought that we needed a discussion of, what was happening and what we could do to prevent another disaster and build a better system. And it's very timely that we're doing this today, because today the bankruptcy court approved the sale of the remaining 6 hospitals for a total of $343 million. So we brought together a group of people who are committed and connected to this story in one way or another, including myself. I'm a former vice president of 1199 SCIU, and I helped organize many of these hospitals into 1199, and I negotiated many of the union contracts with the Steward system. And if you're wondering, did I know Dr. DeLatorre, or we used to call him Dr. D, Ralph, to many? Yes, I did know him, and that's another conversation. But, I have to say, we won good contracts for our members with good benefits. But all along, we knew that the system was in trouble. Our members constantly complained about short staffing, lack of supplies, vendors not being paid. So the red flags were there. They were there early. So before we actually get into the conversation, I just wanted to review very quickly what the history was here. So I have 2 slides. Jonathan, could you put the first slide up? And this is not this, what I'm going to do is just start this timeline. It's probably hard to see, but at least I can, follow it and just give you some of the highlights. In 2010, we had the Hattis healthcare system. Carney was part of it. Good Samaritan was part of it. They were Catholic hospitals, and they were in big trouble. And that's the system that Dr. DeLatorre took and basically sold it to a private equity firm, Cerebus Management, which converted it to a for-profit company and named it Steward. And the Mass Attorney General had to approve the sale. And the AG at the time was Martha Coakley. And she had monitoring oversight of that sale and set, and there were certain conditions that were established, like continued oversight. In 2011, the system acquired Morton and Taunton and Quincy, Medical Center. And the deal required both facilities to remain open for 10 years, which would have taken us to 2021. But 3 years later, Steward closed Quincy, pushed the patients to Carney, and the state monitoring of Steward ends. And already, debt was being incurred by the company. In the period of 2016 to 2018, Steward sells the land property to Medical Properties Trust for $1.25 billion. And Steward becomes a national chain. In fact, it even moves to being international. Trying to create a healthcare system in Malta, Colombia, Doha, and some other, interesting locations. Next slide. And then, we see the real cracks coming in 2020. The doctors group that led by Dr. D acquires 90% stake in Steward. Medical Property Trust owns the rest, and debt continues to mount. Steward announces its plans to sell Sinai and Stoughton, and vendors all over the place are complaining they're not getting paid. And now we come to 2024. I don't really need to repeat everything that people have read in the paper, but mostly, what's important is the Haverhill mayor actually called it a Ponzi scheme, which, is one way to describe it. Healy demands action. Steward declares bankruptcy in May, and the company is $9 billion or more in debt. And, Healy, and this administration seeks for action. And we know what, happened in the last 2 months, which was, the potential sale of, 6 of the hospitals, including St. Elizabeth's to Boston Medical Center, the whole issue of eminent domain, which we'll talk about, and Carney and Neshoba close August 31st in violation of DPH regulations, which requires a much longer lead time. So that's the history. And I'm going to just explain quickly the format, and then we'll get into our speakers. So tonight, we're going to, basically have a conversation with, hopefully a good amount of back and forth. I'm going to moderate. Each person's going to have a short opening, and then I'll be asking people some general questions. We'll try to have give and take. If you have particular questions, please put them in the chat. We will be monitoring the chat. And hopefully we'll get to incorporate some of the questions. We'd like to think that our questions at least cover some some span of important questions here. And, basically, let me now introduce our speakers. We have Dr. Alan Sager from BU School of Public Health. He's a professor of health, law, policy, and management, and he's director of the Health Reform Program at Boston University School of Public Health. And he's been conducting research for years on hospital closures. We also have Bill Walczak, who is the founder of Codman Square Health Center and many other renowned Dorchester institutions. He was also, for a brief stint, the president of Kearney Hospital. And when I asked Bill a while ago, how do you want to be introduced? He said, Dorchester activist. So we're proud to have an activist here. Katie Murphy, who's a certified critical care and neuroscience nurse, I believe at the Brigham, and president of the Massachusetts Nurses Association, which represents over 20,000 registered nurses in Massachusetts. And Dr. Paul Hattis, who's the senior fellow at the Lown Institute and has written exclusively on the Steward crisis for Commonwealth. And also, I believe, too, has a relationship to have been the medical director at Kearney at one point. So we have, definitely a distinguished panel. And what I'm going to do is ask each of you like a really basic kind of question, and then we'll get into some more, more dicey questions. But first of all, maybe Alan, we could start off and, for a couple of minutes, just give your perspective on how did we get into this mess? Like, how did we get here on September 5th, where we're, how these hospitals are being sold, bankruptcy, eminent domain. So why don't you give a take? And I think what we would like to try to do is like 3 minutes or something on that. And I'll just briefly, I'll roughly time. We're not, if you're saying something important, we don't want to cut you off. Alan?
How'd we get into it? As has been said, there's no functioning free market in healthcare. Most of the legislature and most of our recent governors would like to believe there is one, because then they don't have to do much heavy lifting. The market will justly decide which hospitals or doctors or nursing homes should live and which should die. That's convenient for them, but it's dangerously foolish, because not one of the requirements for a free market can be satisfied. You don't get innovation, you don't get efficiency, you don't get affordable care, and you don't get the care we need. And nobody pays attention to which hospitals or doctors are needed, where, and how much it costs to keep them open. At the same time, there's no functioning free market. State government has been chronically incompetent and willfully disabled, self-disabled, working in healthcare. They've had many opportunities for decades to get on top of healthcare, to figure out which hospitals are needed. There's even a state law passed in 2012 that requires the state to inventory what's needed and what's not. The state doesn't have a good hospital receivership law. So the state walked into this crisis without forging the tools needed to cope with it. You might call it willful unilateral disarmament. And when you don't have either a functioning free market or competent government, you're left with anarchy. And I'm not talking George Orwell, Homage to Catalonia, Barcelona, 1937 anarchy. We're talking chaos. The world's most expensive healthcare, $45 billion a year for hospitals this year, enough to keep open every needed hospital, $125 billion for healthcare overall. That's $18,000 per citizen of Massachusetts. Now, it's not enough for immortality, but it's enough to give us the care we need, all of us, without copays. But state government gets engaged when there's a crisis. They go into excitement mode. And maybe that's exciting for them, but it reveals the depth of their incompetence. The governor has not been honest throughout. One of the things that's worse is we have this notion that that the hospitals are bidding for land and buildings to buy them. 343 million. It'll be more, probably. Where's the money coming from? It's probably going to actually end up coming from the state. So it's you pay now or you pay later. And a lot of this goes back to 2010, when the Archdiocese wanted to get out of the hospital care business. And it looked like Ralph, and you can call him different names, but I'd like to be on record that his real name is probably, or his nickname should be, Ralph Deleterious, because he does bad in the world. And he can make a sale, but he doesn't deliver. And
Okay.
we could do better.
Bill, what are your thoughts? You're muted.
Mute, unmute. Got it. All right, so mine's going to be a little over 4 minutes, just so you know.
Okay, I stand
I
warned.
wrote, all right, because I wrote 3 really long columns for the Dorchester Reporter because I have a more than 50-year history with the Carney Hospital, mainly as a person that worked with them and starting the Codman Square Health Center and being part of all the efforts to try to save it all of the years, and then a year, 14 months as president back in 2011. Anyway, so you can, for those of you listening, you could go to .com, so DOTNEWS.com, DOTNEWS, and read these columns, which are really long and really detailed history. In the 1970s, when I was involved, the Carney was a huge hospital, 400 and something beds, with 10,000 admissions. And it was very focused. There were parts of it that were very focused on the Dorchester community. And like, for instance, the community-oriented primary care program that I think Paul was involved in, and really involved in starting or sustaining 7 community health centers in Dorchester. At some point, at various points, it decided to turn its back on the Dorchester community. And as a result, it was the community health centers wound up reorienting themselves towards downtown teaching hospitals, which resulted in the Carney Hospital shrinking. But that doesn't mean that the Carney should have closed. Community hospitals should be core elements of regional health planning. But we don't have health planning in our Commonwealth, Massachusetts. We apparently have a market which speaks. The problem is that the market doesn't care about health. It cares about money. And the market is currently rewarding extremely expensive hospital systems, which don't help out in lower income communities like Dorchester and Mattapan, which are the service area of the Carney. Just beginning in the beginning of August, I made the following case for saving the Carney Hospital when it came up. The service area of the Carney Hospital has over 200,000 people living in it, including populations with among the poorest health outcomes in Massachusetts. Forcing this area to deal with poor emergency room access at a time when it would take way too long to get to the downtown hospitals, and the fact that those emergency rooms are way overcrowded is malpractice on those communities. Eliminating 50 psychiatric beds at a time when patients can stay for months as boarders in an emergency room for lack of psych beds is irresponsible. Acting like we have a functional market that makes responsible decisions ignores the reality that our market has produced chaotic, fragmented, and outrageously expensive medical care. And the last point was, since when does the leadership of the Commonwealth of Massachusetts allow a bankruptcy judge in Houston to determine how healthcare gets delivered in Massachusetts? Obviously, that had no impact. So in mid-August, I wrote that the crisis that seemed to erupt when Steward declared bankruptcy was actually very predictable. And in fact, information on the future bankruptcy was available 2 years earlier in no less than the Wall Street Journal, a large article in the Wall Street Journal. So with that, I recommended the following. 1, seize the Carney Hospital by eminent domain and work out an arrangement for BMC to take over the Carney Emergency Room, as it did and does with East Boston Neighborhood Health Center. or they could entice the Beth Israel Lahey to expand Milton Hospital's emergency room to jointly run with a second site at the Kearny. Second, create a network of community health centers to open up an urgent care center in the Kearny Ambulatory Care Center that would operate 7 days a week. 3, turn over the 50 psychiatric beds to the Department of Mental Health. 4, establish a commission to look at alternative uses for the rest of the Kearny property, which could include surgery center and other clinical and low acuity operations, and using the laboratory, X-ray, and other imaging services on site. And 5, pass legislation that gets Massachusetts back into effective health planning. We got nowhere, and hearing that nothing, except hearing that nothing could be done, and the bankruptcy judge was the most important. So the hospital closed, and I wrote the following. In the case of our Dorchester community, DPH and the OHHS protected the interests of the very flawed marketplace, which includes equity firms that purchase hospitals. Health didn't rate. How else to explain their decision of Robbie Goldstein and Secretary Walsh to allow the steward to close 2 hospitals, one in a rural area many miles away from other hospitals, the other in a low-income area with large numbers of people of color and among the poorest health outcomes in the state? That they also allowed the steward to close them in 30 days in violation of their own state regulations that require 120 days indicates that they were not interested in addressing the health consequences of the hospital closures. 30 days is not enough time to determine how emergency care will happen, where primary care and specialty patients will be seen, how medical records will be transmitted to other sites, or to communicate with the community of over 200,000 people. It's just not possible in a truncated timeline. Our local healthcare system does not have the primary care and urgent care capacity to replace the lost Kearny services. Local community health centers have long waiting lists for primary care and do not have urgent care capacity to service any part of the 31,000 patient visits of the Kearny ER that now need to go elsewhere. Several of the health centers do not have urgent care, and for those that do, weekend hours are extremely limited. Health center requests to the state for expansion of urgent care hours have not been supported. Yet, if granted at the level of financial support necessary to staff the services, it would take months to ramp them up.
Bill,
Yeah.
because we're going to cover some of these other questions. So why don't we give up 2 other people a chance just to start with their comments?
Okay,
and then
I'll just finish with this.
Okay.
It's a disaster. And what's made worse is that, most of what we were told was absolutely false. With the bankruptcy judge was in charge, eminent domain, whether there was money, there's plenty of money, and that the state didn't want to get into the business of running a hospital when in fact it currently runs 4 hospitals. My view is that, and then we find out yesterday that BI Milton Hospital is going to greatly increase the size of their emergency room, millions of dollars when they could have just taken over the Kearny Hospital and run 2 ERs. My view is we need new state leadership when it comes to healthcare. This system
You're going to
is
get
not
asked that question. So I'm not
Okay.
trying to cut you off. I just feel like we're trying to move, have a conversation in many different directions.
Gotcha.
Sorry, I'm not trying to be rude. Katie? Your
There,
perspective?
I'm there. Unmuted, right? Hi, everybody. I also cut my piece down, and I hope I'm under 4 minutes. I want to thank.
Can I just say one thing? Well, I feel
Yeah.
like we have a lot of questions that people will get to, and the
Okay.
idea here is just to get quick thoughts, and then we'll get to some of the things about what you think about state leadership, about eminent domain. I think we try to think about it that way. So, not
Great,
trying to
thank you.
anybody.
No, you're right. That the conversation is the most powerful. I just wanted to say, I wanted to start out to saying that I'm happy to announce that I agree with HHS Secretary Kate Walsh that the market has spoken, and why we would turn over our most precious lives to a for-profit industry is stunning, heartbreaking, and deadly. We represent over 25,000 nurses and healthcare professionals across the Commonwealth, including 3,000 in the Steward system. And as these frontline providers, we have a unique perspective on private equity and the for-profit ownership in the acute care sector. We can also provide, as you've also talked about, the unique historical perspective, as our members have worked at nearly every facility owned and operated by for-profit entities, or the private equity firms or traditional for-profit providers accountable to shareholders on Wall Street, since these firms first entered our state, as you noted, in the 1990s. And for the nurses and the healthcare professionals of M&A, our immediate view of Steward crisis is a glass at best half full, where we really appreciate the efforts by local operators in the state to find a way to preserve the 5 Steward facilities and look forward to with cautious optimism to a new era of care quality and stability for these communities served by these facilities. However, we see the failure of the state to act to save Kearney and Neshoba Valley as a blatant abrogation of the state's responsibility to protect the public health and an abandonment of the more than 250,000 residents served by these institutions. And we're equally appalled to read statements by a DPH commissioner that the vulnerable community residents of these communities and the officials who fought so hard to save them need to, and I quote, imagine a new future for healthcare or these communities. It's at best disingenuous and worst insulting to those who will suffer from the state's impotence and failure to protect the public health. Let me just skip, as we testified at both DPH hearings for the closures, that the only option, the only safe alternative to closing a community hospital is to not close that hospital. And we feel that the sad thing about this tragic outcome is that none of it had to happen. As nurses and health professionals on the front lines, we have been the canaries in the coal mine about the Steward system, sounding the alarm about the pending crisis for years. In the last 2 years, we have directly informed the administration of what we were seeing. The lack of staff and resources, the chronic lack of all types of supplies due to Steward's failure to pay their vendors. We filed official complaints, reported patient deaths, including the death of a new mother at St. Elizabeth due to the lack of a special coil to stem her bleeding, a coil that had been repossessed for lack of payment. We picketed, we sent memos to DPH, and we specifically reached out to the administration months before the bankruptcy, warning them that this was coming. And here we are struggling to save a handful of hospitals while magically imagining an unsafe future for the others. Our focus must be on the legislature, and I look forward to talking about that a little bit later.
Okay. Paul, how did we get into this mess?
Right. So let me first of all, I appreciate being invited here and joining the distinguished panel, and I look forward to our back and forth. Let me just name 3 themes I think people ought to think about when they think about how we got here. And they, in some ways, Katie, Ellen, and Bill have touched upon aspects, but just let me reinforce it. One is, in the absence of a single payer system, we have a system where we have haves and have-nots that result from the fact that certain patients, better insured with more money, go to places where those dollars follow them, and those institutions can do just fine. Places which are mainly seeing government-insured patients, and significantly either uninsured or Medicaid, and even a member of Medicare, they don't do as well. Caritas Christi, which was the progenitor system before Steward, was a have-not system. Okay, wasn't all that well managed. Lost money, not huge amounts of money on operations, but took on about almost $500 million of unfunded pension liability that was making the system struggle. One owned by the Archdiocese at a time after they had already gone through their own economic turmoil following the sex scandal of 2000, early 2000s. Okay, so you have a have-not system. Ralph becomes the head of it in 2008. He did try to shop it locally. None of our local nonprofits were interested, nor was Ascension Healthcare, the largest Catholic hospital system in the country. And so with this have-not system, alien failing, he sold it to Cerberus, okay? And I won't go through, we all know the negative route of history that resulted in, actually the most intense negativity, I think, happened after was 2016 when MPT was brought in, a real estate investment trust. Although, the dividends paid, I won't repeat all the history, but the part I want to observe about this is, I know Alan called it willful disarmament. I think government has failed over the course of time. Okay, not because they wanted to. Okay, although you wonder when the legislature doesn't do the kinds of things Alan suggested, like receivership laws or hospital stabilization laws, or the regulatory oversight scheme seems weak or unenforced at times. I think the reality is that part of the reason they did so poorly is they were not used to dealing with a private equity firm managing healthcare. As challenging as some of our large, wealthier academic nonprofits are, who use traditional market domination and controlling prices to dominate, they weren't used to this private equity model, which is really scandalous in many ways. And so the oversight of Coakley was okay initially, but then that went away completely, and most of the terrible things started happening in 2016. That was the second theme. The third theme, of course, is that even when I think early on people got wind of some of the negativity of what Steward was doing with all of its partners, and then saw even in 2016 when it was sold to MPT, and then they took the money rather than investing in our local hospitals here, went on a buying spree the rest of the country. Again, governments sitting idly by during that time, and really not adequately trying to get at what is happening with the money, what's happening with those hospitals. Katie just observed what the nurses were seeing in front lines, et cetera. I'm going to stop here, but I think those three issues, the private equity, government's sort of not really up to the job, and historical haves and have-nots are themes that help get us to where we are today.
Okay, thank you. I'm going to pick up with the haves and have-not theme, because when Steward was created, the goal was to provide care in a community-based system that would be a less expensive alternative to the academic medical centers. And the hospitals were located in many challenged communities like Taunton, Brockton, obviously Dorchester, Holy Family, up in Merrimack Valley. And Steward, claimed that one of the reasons it could not succeed was because the low rates for reimbursement for Medicaid and Medicare. Obviously, corporate greed, we know that, just terrible things, but I'm just curious how you respond to this issue of what was the response of how the state should have even looked at this issue of have and have nots in terms of funding, and then we can move on to some of the private equity questions. I know, Paul, maybe you could start that conversation, and then Alan.
Well, let Alan
Not everybody
start.
has to answer every question, but I just feel like this question of being able to at least deal with the question of reimbursement is not an insignificant question.
Since I just commented, let Alan start first, just to have a different voice.
Okay.
And I can start. Go ahead, Alan. His hand raised. So
First, we can't let these clowns play poker using our hospitals as chips. Second, Ralph knew going in what the payer mix was. It's no excuse. Third, in the real world, if there were a free market, everybody would pay the same price for the same care. Like we go to the supermarket, everybody pays the same price for a gallon of milk. Maryland makes that happen for hospitals through all payer, regulated all payer. All payers pay the same price for the same care. And so if you're in a certain neighborhood or a certain town, you are financially whole. So there are ways of doing this. Paul has made some very important points about, and only one of them had to do with the state's unfamiliarity with private equity. But this shows how incompetent, once again, state government is, because private equity is not new. They cannibalize department store chains, supermarkets, factories for decades. And not just private equity, but other for-profits. So this shouldn't have come as a surprise.
Paul, you want to jump in?
I'll say that I think there's the have-nots, which exist under Caritas Christi, they exist today in many of our community hospitals, and they'll exist tomorrow with these Steward hospitals as they're taken over by their new owners for the most part.
Oh, okay.
That's a real issue.
Thank you for dinner.
The reimbursement.
Very nice.
Oh, sorry.
We're calling for Ivan.
Katrina, please mute yourself. Thank you.
Might want to mute. So, you know, the lack of single payer, the fact that we have differential payment, the reimbursement challenges are going to continue for the new owners. So to that extent, you know, Care is saying we had a bad payer mix financially. That was true, but as Alan said, they knew going in, and they tried to convince the world that they had a magic formula to do things differently. You know, and you know, they even believed that the ACA was somehow going to create this fertile oasis of the desert. You know, in some ways, for them. None of that materialized. Then you add COVID on top of it too, and that really even threw them, you know, for another loop. So I'm not saying that everything that happened to Steward was by greed and mismanagement. There were structural issues there, but then there was neglect of really dealing with the underlying, you know, issues of the institutions. At least, you know, and basically at that point, the goal was just to bleed them and pay dividends out, you know, once they really got their model going. So,
Bill, as the president of Carney, what thought do you have on this about, did reimbursement play a role, irrelevant?
I think there was this notion that somehow, you know, people with better insurance would start coming to Steward or hospitals. But you know, we all know how the system is rigged, and it's rigged so that, you know, if you're Newton Wellesley Hospital, you don't have financial problems because you have a lot of private insurance that's going to pay a much higher rate. And if you're in an area that has lower income, so it's the same kind of class-oriented decision making, and the state has to make a determination as to whether it wants to have that kind of system where, you know, if you're in the western suburbs, you have lots of access and lots of opportunities. And if you're in Dorchester, you know, you lose your hospital. And I think the state also needs, as you know, been pointed out by a number of people, is, you know, comprehensive planning that really kind of understands what the needs of communities are and has a healthcare system that's paid for, that is going to work on making sure that every part of the Commonwealth is as healthy as it can be. And that is not what we have, unfortunately. We've lost the ability to comprehensively plan for Massachusetts health.
And Alan's point that in Maryland, hospitals basically get a fixed budget. They know what they're going to get. They're guaranteed that revenue flow. We don't have that in Massachusetts, and I think that helps a lot to know from an expense planning, as well as assuredness that you have dollar flow, and it's not about chasing the next patient for an admission.
Right.
It's about living within that budget to try to, you know, manage what you have. And so I really do think the state ought to look hard at such a global budget scheme for inpatient care.
Katie, thoughts?
Yeah, just two quick thoughts. You know, I think that wasn't it reported in the paper that actually the Steward system or some of the hospitals did have equal reimbursement, which, you know, really as frontline caregivers, we don't believe that your healthcare should depend on your zip code. And I think clearly, you know, maybe more so with the closing of Kearney versus Neshoba, even though I think it is equal, in this state, your healthcare depends on your zip code. And I think the state has a compelling interest in getting involved there.
Okay, let's switch gears a little and look at the whole issue of private equity in Massachusetts. I'm going to quote one of our panelists, Dr. Sager, who says, "Trusting profit-making healthcare is believing in the tooth fairy." So I don't think we have a tooth fairy here, but let's talk about the fact that, you know, we have opened the door to private equity, Tenant, and certainly Steward. What's the role of regulatory oversight in mergers, acquisitions? You know, obviously, you know, market prevailing does not always answer the problems. So what should the state be doing, and what should the state have done to actually protect healthcare, protect consumers and patients? Anybody want to take a stab at that question?
Let me start with the private equity, because it's important to distinguish between other publicly for-profit traded companies. And the point that I just want to make is, even though most of us think we ought not to have a system where for-profit ownership, you know, has much significant presence, certainly, you know, let's say on the hospital side, when you are a publicly traded owned for-profit, at least there's the Security Exchange Commission has oversight to your financial reporting and your behaviors at some level, because you can go to jail for violating security laws. Private equity doesn't have those kinds of oversight provisions attached to it. It's sort of out doing its own thing. And in addition, it doesn't, as was happening in our state, Steward decided he didn't want to report financials to our state agencies, and our state agencies ultimately chia suit over it. But I even think to this day, they still haven't gotten those financial reports. So when you have a weak government oversight system and no SEC looking after you, private equity is really hanging out there. And I'll just add this one word and let others comment. It's creeping into all sorts of aspects of healthcare. Physicians now, 10% of all docs in this country are private equity owned. And when they take over those practices, all of a sudden there's a push for higher volume, higher reimbursement. We had a bill in our own state legislature because of the fact that the wheelchair industry is now owned by private equity. You can't get your wheelchair fixed anymore because the wheelchair manufacturers have made that so difficult they want you to have to buy a new chair. So it costs consumers who are disabled, and need a wheelchair, huge amounts of money. I'll stop there. You could read about it in hospice industry, home health. Private equity does not seem to be something that's value added in healthcare for the American population. So,
and it's my understanding that private equity owns approximately 460 hospitals in Massachusetts, in the country, which is quite a large number. So, Alan, Bill, anybody else? Katie, want to comment? What should the state be doing on private equity? Yeah, Alan.
So there is, as Paul says, there's a distinction between the two kinds of for-profits. But I think, unfortunately, when we see Columbia HCA stealing 1.7 billion, if Tenet were an individual criminal in states with 3 strikes and you're outlaw, they'd be in jail for life because they stole 9 figures 3 times. So I think without a functioning market to discipline profit seeking and turn it into the public good, the way Adam Smith had in mind, it's a joke. And I don't think I fear it's not worth talking about. A big question is, why doesn't, although other people certainly have legitimate arguments otherwise, I think the core question is, why doesn't the state act? And that's a political problem by definition. So politically, why did the governor get away with closing the Kearny and Neshoba? Who was pushing for it and who wasn't fighting inside? Does the governor listen to anyone? Who does she trust inside the administration? There are few people in the legislature who know exactly what's going on. Is the problem that the legislature is so top down that those voices got muted? If we can't count on profit seeking and a functioning free market in healthcare, and if we can't count on government, we're going to keep wasting half of the $125 billion a year we spend in this state on healthcare.
And do you have a solution?
Well, I think one solution is a new governor. A second solution is the kind of legislative leadership and pay reform that more and more people are talking about. I think many parts of the legislature are rotten and paralyzed. I heard from one very smart person today who said something I hadn't ever thought of, which is that the legislature thrives on chaos. And state government thrives on chaos, not on competence. Another very smart person, I thought, said, maybe the problem inside the administration is too many lawyers. With all respect to lawyers on the line today, it's a question of balance. And maybe there's too much of one side thinking about prosecution and moralistically pointing fingers at Ralph. instead of fixing healthcare.
I'm going to ask everybody this quick question, and then we'll go back to the conversation. If you were to rate what the governor did on, like gave them a grade, A, B, C, D, whatever. Okay, so Alan, you spoke. What grade would you give the response on Steward?
D+.
D+, okay. Bill?
Actually, I'm a person that believes that that the governor had been listening to Kate Walsh, and that when Kate Walsh made her first statement about that the market has spoken, she kind of parroted it. The governor parroted that, and to me, I think just a terrible mistake was made in choosing Kate for that job. And what we need is a person in the leadership there that doesn't believe that the marketplace is the way in which our healthcare system operates. So in terms of that, I would say that Kate has gotten a failing mark.
Okay, that's an F. Is that how we rate? I just want to make sure. Some school systems consider D to be failing, so I'm not sure. Katie.
I certainly I want to throw out a grade, even though I feel like there is just so much blame and incompetence to go around, and I certainly agree with everything I've heard. When we were doing a ballot question several years ago, we were also talking about a transparency bill. We wanted to see that go to the Hill and become law, and it was transparency about CEOs' salaries, and it was enormously popular. So it's so interesting to me that in this state, there's a huge disconnect between the leadership that we see on Beacon Hill, and it is, I think, that is highly concentrated. I think we have some wonderful legislators there. And there's a big disconnect between the good folks of Massachusetts and then the people who get that power. So I guess
what's the grade?
A C-.
C-.
I'll give a C-.
Okay, and Paul?
I'm going to give the governor the highest grade. When I say highest grade, not the highest grade of A, the highest grade of our group. And let me explain why. And John McDonough and I wrote about this, going back to January, which is we accepted the notion that in some ways at this point of even this is before the bankruptcy filing, that societal factors and mismanagement had led these acute care hospitals to the place where they're at. And given all the amounts of money that would have to come forward to maintain all of them as acute care hospitals, we didn't think that was likely going to happen from state government. And lo and behold, we were right. Kearney and Neshoba, which are essential as behavioral health institutions, but much less so as medical surgical inpatient hospitals. They had 10 or 15 down to, as Bill said, at one point the Kearney had 300-400 patients 30 years ago, was down to 15 medical surge patients a night. So the idea that you would insist that they stay open as acute care general hospitals when you're down to that volume, I didn't think that necessarily made sense for the governor or the state to force that to happen. What I do blame the government for, though, is there has been no plan come forward for how those sites really ought to be fully utilized. Bill has written very effectively, and I've commented about this too, that maybe inpatient behavioral health needs to happen there, urgent care, emergency services. I won't go through the whole laundry list, and social services. Even a healthy village concept. But even today, we don't really know the plan for Kearney or Neshoba, and that's distressing. Having said that, we have at least, and I'm sure Ellen at least was a little bit hopeful about this for the moment, save the other 5 acute care hospitals at a very significant price. The state today said it'll be at least $489 million of government dollars over the next 3 years. I think that's a huge underestimate because none of that includes capital dollars that are going to need to be invested. And none of it, I think, applies to St. E's, which has its own not only eminent domain proceeding to buy the land, but its building probably is the most expensive of all to replace. I think, so I'm going to stop there. But
right.
That's so my grade after all of that, I'm going to give her a B.
Okay. All right, before I call on you, Alan, I guess one question I would have for all of you is, given that we knew there was this crisis, brewing, not just in 2024, but what should the state have done? What should the AG have done? What should the governor have done? Not just Healy, but Coakley, other governors. So Alan, as we're talking about the role of government, I'm curious what people think about that.
Some of what we see at both Neshoba and the Kearney is a classic case of somebody killing their parents and then demand to be treated respectfully and kindly as an orphan. If you run the place down, there's not much left, but that's not the same as need. And when Kate Walsh says, and forgive me if this sounds too much like piling on, when she says, well, we need urgent care at Neshoba, so when people think they might be having a heart attack or a stroke, they can go someplace close. That does, from the little I know clinically, that doesn't sound like the right idea. And also, the cost of keeping Neshoba open is tiny when you're spending $45 billion a year on hospital care. So I think the money's in the system. Also, think back to when President Kennedy was elected. I think most of us were around then. There were 140 hospitals in Massachusetts, and this goes directly to your point, Enid. We're down to 60. That's a big drop. And Steward alone may end up being accountable for closing 6 of its 12 hospitals, because we hear talk about Morton not being run as an acute care hospital. We hear talk about Haverhill not being run as an acute care hospital, on top of Norwood and Quincy and New England Sinai, other places. So this is hospital side, and the state allowed it to happen. I think Paul addressed that in very important ways in describing what was going on in 2010. But that was a legacy of, as Sandy and others have said, of deregulation and of the absence of health planning. But let's be realistic. I was a vice president of Health Planning Council of Greater Boston. We did not accomplish very much. There was not much political support then for what we did. There was federal money to pay for staff and to do certain things, certificate of need review. There's no constituency for health planning. There never has been a serious one. So stepping back and thinking, what do you do when the market is broken? You need a substitute. Who's going to take on the leader? Who's going to fight for that and make it a big platform in their campaign for governor or Senate?
So I'm just curious, like you've all given your grade on the role of, the governor, but what should have happened between 2010 and 2024? We didn't just get to this today. This is a long-term crisis. So what should the state have been doing? What should, governor or whatever be doing? Katie, Paul, Bill?
We have a Department of Public Health that is absolutely toothless, and we know this firsthand because we have participated, I think, in over 20 campaigns to keep hospitals and services open. So, there's language that says, the 120 days, and there will be hearings, and the community, and we go to the hearings, and there's really, really thoughtful testimony from, think of all the municipal leaders, in addition to the healthcare providers, the community members that testified on all of this, and that we testified on closures of other hospitals. And last year, the Leominster Maternity Unit. And the DPH listens very carefully. They issue a report that this is an essential service, and then says we have absolutely no power to keep it open. Now, these are public servants paid for with public dollars, and so I think that there should be, an actual a robust Department of Public Health that does exactly that, protects the public health, and we can find a funding source. I've identified the billions of dollars that are is awash in this system, put that really to good use. And so when and legislation has been filed, and we worked with Alan Sager on filing this to also, analyze the need, the capacity and the needs in each community. For instance, when they closed the maternity unit at Morton Hospital, I think to Paul's point that hospitals don't have services, and so nobody's going there. It's really death by a thousand cuts. They take away a service, and I think, Bill, didn't they do this at Kearney? They got rid of the urology service, and there's a big facility nearby where that people have a lot of needs for urology services, and then they can say they couldn't go to Kearney anymore, and then Kearney says, Steward says, see, no one's coming here anymore. So I think that by analyzing the needs of the community, giving the DPH real legislative, real financial standing in which to enforce this in a community, that is a role for government.
We name a few other holes in the regulatory scheme that in theory the legislature is only finally starting to catch up with. One is, if you are going to operate under any ownership structure in the state, you don't follow the necessary required financial statements, you should lose your operating license rather than be able to go on years and years and fight in court and nothing happens. Okay. The HPC should have been able to review in 2016 when Cerebrus sold out to MPT, but the reality is of the HPC jurisdiction, and this is—
Why don't you say what the HPC is?
Health Policy Commission reviews when hospitals change ownership, except it's only when they change ownership from a hospital to another hospital. When you just sell the land and buildings to a real estate investment trust, even though that transaction was sort of part of the, as somebody called it, the beginning of the end of the Ponzi scheme, it didn't even, the HPC didn't even hear about the transaction because it's a hole in the regulatory requirement, in the sense that you even have to let the HPC know about it. Those are just to name a few of them. Alan's talked about the receivership law, the hospital stabilization fund. So we could see, that there's some basic infrastructure that's been missing in the regulatory scheme, and I haven't named everything. So.
Hey, Bill?
There's more than that.
Let me throw one other question at you at the same time. Should the state have taken over Kearney by eminent domain as well?
Absolutely. Yeah. I think they still should. We know that 6 hospitals were sold for $343 million. Wasn't they, the overall, they got $1.2 billion out of the healthcare real estate firm in Alabama.
They paid $1.2 billion to Cerebrus, and Ralph put some of the money in his pocket then too at that time.
Right, but they only got $343 million. So obviously these hospitals are worth less than they thought. And maybe those hospitals that, Neshoba and Kearney should be picked up like immediately, just like, work out whatever the deal is and take them over so that we can start thinking about what the utilization of that would be. I think, the real estate trust organization was looking probably at the real estate value at the Kearney Hospital rather than anything else. But one of the other issues that I think has to be dealt with is the kind of thing where that everybody in the healthcare system can figure out ways of creaming the insurance system and all that. So, at the Kearney, one of the things that would happen was that patients who had, like, say, Blue Cross would be referred to a surgery center that was partially owned by the doctors who were providing the services. And the Medicaid patients were at the Kearney Hospital getting the lower reimbursement. And so those kinds of issues, we maybe that, all payer kind of thing and all that, you get what you want or whatever. But I think there are just so many flaws in the healthcare system that we have that, in my view, has always been single payer, but there has to be ways of regulatorily kind of fixing some of the big, huge issues that make things not happen in any reasonable way and drive, the people that happen to have services in low income areas into the ground.
Reflecting a theme that's coming up in the chat is, okay, we agreed that, that Neshoba and Kearney should have been taken over by eminent domain or some major action. What do we do now that it's September 5th, 5 days after the hospitals was shuttered? to, move some plan. I was on the ground when North Adams closed, 4 days notification. And the Attorney General was powerless to do anything, even though she filed an injunction because the hospital closed and they canceled the malpractice insurance, so no doctor would walk into the hospital. So, that sort of was the beginning, very quick. And so here we are, 5 days after the hospital closed. What should people be doing? Is there something that we could be doing as a collective group to push the state and the governor to do something? I'm just curious. You're all experienced political people. What thoughts do you have?
We'll start with Bill.
Sure. Some,
Yeah, I mean, well, first of all, you need to have possession of the properties. The properties are, for instance, the Carney Hospital has imaging services that are still in there. They have the laboratories that are still in there. It could definitely operate an emergency room there and an urgent care center and provide, surgical and other kind of low acute services in there, while you try to figure out, and also they have the psych beds taken over by the Department of Mental Health. I mean, these are things that could happen pretty rapidly. And then, then you call kind of the neighborhood leadership together and try to figure out what are the needs of that particular neighborhood or those neighborhoods in Mattapan, Hyde Park, Dorchester, Quincy, and, in parts of Milton. What are the needs of that neighborhood, and how do you structure a comprehensive kind of system of care? And maybe that would allow us to start moving in other directions, such as other psych and other behavioral health kinds of programs that could be put in there, because we know that how difficult it is to get people into those services. So obviously there's a need, and right now we just added 50 beds of not having 50 beds into that mix.
Mhm.
So
Others?
here's
How we
my
take
corollary
action?
about that. But go ahead.
Sorry, Paul.
No, Kate, you go first if you have an idea. Or
I think that, I agree. It's only been 5 days. I don't know why we didn't act fast. Well, I have my thoughts on why we didn't act faster. But, I think keep searching for providers who are interested. I mean, there has been, at various forums that we've been attending, there's talk that there have been people interested in taking over these facilities. And that was our push for 120 days. At least give us the 120 days, to keep looking. So, I would keep looking. I would keep looking.
So here's my thought. At this point, with those two hospitals now closed, and I want to believe, although who knows, maybe there's still some last minute things that are going to happen, that the state can finally move its attention from the selling of those 6 hospitals to what's going to happen with the Kearney and Neshoba sites. I realize that those deals don't close until the end of the month, and stuff can always still happen. But assuming that doesn't blow up and the state doesn't have to put all its attention there, look, Apollo still owns the land for Kearney and Neshoba. I would say, maybe if I were the state, maybe even the governor, say, I'm going to give you 45 days to find partners that you can sell the site to, that are going to, have a plan and a vision for, inpatient behavioral health, urgent care, maybe, some list of service expectations, and give them 30, 45, 60 days max to figure it out. If they can't do it and they can't make a deal or come up with a plan and say, we're going to be selling it to so-and-so to do A, B, and C, then I think the eminent domain is where the state asserts itself. And then the state goes in and tries to find those partners to affect that plan. Yeah, and it'll cost them maybe a little bit of money, but as Alan says, they already are spending, we're spending what we're already spending in the state for healthcare, to spend some dollars now to figure out how to make those sites viable. And we're not talking, this is not like spending $400 million to build a new hospital building. I think we're talking magnitudes much, 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 much smaller to figure out, at least for the outpatient component, building a new inpatient psychiatric facilities that's state of the art, that is going to take some real money. But the state ought to be involved in some plan to at least try to make something like that happen. That's my thought.
It's very interesting to contrast the good ideas that have been raised with what the legislature's actually been struggling with and failing to pass a bill for the last 10 months. Basically, they're thinking like the French army preparing to fight the last war, preventing a specific repetition of Steward. But there's no real analysis of your question of what went wrong when and what could have been done better. So the chair of the Health Policy Commission was quoted as saying, well, after Steward moved to Dallas, we kind of lost sight of them. And that speaks to an institutional mentality in state government of not paying attention, not putting your arms around healthcare, and imagining that some phony market is going to fix it for you. One thing to do would be along the lines Paul suggested earlier in the question of if you don't file your financial report. Declare each surviving acute care hospital an essential public facility where the licensure is conditional on affordably delivering needed efficient care. And if you mess up, you forfeit the license, and a receiver is in, you're out at 5 p.m. A receiver is in the building at 7 a.m. tomorrow morning, a skilled hospital administrator. And you lose control of a hospital. So the hospital is not a piece of property, it's an essential public service. And then the state then the state DPH and others may start having jobs they can do, obligations to discharge, where they're accountable. Right now in healthcare, it's all rock and roll. Nobody is accountable for anything that happens outside the building where they work. And not inside, if they can get away with it.
I'll just read a quote from one of the big healthcare consultants in Massachusetts, Ellen Luch-Bender, who says, Massachusetts has put a great amount of time and thought into regulating our healthcare system, yet somehow this corporation just fell through the cracks. Pretty damning. Yeah, interesting quote. So I think that really the question here is like, what can people do? The legislature has a bill. We know that the legislature was dysfunctional at the end and nothing happened. Are there pieces here that, people could, start to really, assuming the legislature is coming back at some point or even into next session, pushing for a receivership bill or something. So there's a number of policy pieces that I feel like, Progressive Mass Care and other organizations, we have 150 people on this call who have an interest in this question. So maybe there's some follow-up here. But I guess my question is, like, there's been debate going forward about outlawing private equity in Massachusetts and making sure there's never any other acquisitions like that. Is that one thing that should definitely happen? What role is there a role? Is there some criminal action? Do we think there's any chance for the Commonwealth to recoup any money here? Just thoughts on what are some other legal questions that will come up here. What role should the Attorney General be playing? The new Attorney General.
I'll just put this out there. I think New York, and someone will correct me if they know differently, has for years forbidden hospitals to be owned in the for-profit organizational form. There might be one small exception if it's a physicians locally can own it. I'm not 100% sure of that, but they just had a prohibition, private equity, publicly traded. You just can't be organized as a for-profit hospital in the state of New York. I mean, they only addresses the hospital piece of it, which, as Alan's already said, maybe is last decade's problem. That's not where private equity is going right now, because they're going in, physician and hospice and home health. But maybe there ought to be some restrictions like that, at least on the hospital side. So it's a thought.
Paul,
Bill?
let's get everybody.
Yeah, Bill? Thoughts?
Our healthcare system is a mess. It's, I wrote a piece about 6 months ago saying Steward is just the tip of the iceberg. There's, we don't have primary care. We're not graduating primary care people anymore, and that's the core element of a effective healthcare system. And it would seem to me that that the way in which we're putting together our healthcare system, I mean, basically you get what you design, right? We have designed this system that we have that is very ineffective, extremely expensive, and very fragmented for the patients. And so, you know, what we need probably is to take a look at what are the kind of regulatory changes that need to happen that would produce a different result. I don't see it happening on its own. I don't see how, you know, how we're going to be able to say, well, you know, more primary care people are going to be delivered into the system because we want it to happen. It has to be done because it's forced to happen. And that goes with all of the other aspects of our healthcare system. So overall, I think, you know, we're in line for I mean, I know that the Flexner report gets a really bad kind of image these days, but at least at the time, they took a look at the overall broader picture of the healthcare system and made changes. Maybe they made the wrong changes, but in any case, what we need is a similar kind of view of let's take a look at our healthcare system, why it costs so much, why it's so fragmented, why it doesn't deliver the things that we want to deliver, why it could collapse like it did, like this, and why, you know, and cost so much money. And just say, well, look, we're going to, over the next 10 years, we're going to be aiming in a different direction that's going to result in a healthier population. Because ultimately, that's what we all need. That's what our economy needs. That's what the business community needs. Everybody needs a healthy population, and we ought to be aiming in that direction rather than aiming in the direction of how the business of healthcare is going to operate.
Should the governor have used the rainy day fund to buy, to use for Neshoba and Kearney? It's a question in the chat.
Why not take the 600 million they just got from the tobacco that, near as I can tell, they weren't expecting? So, you know, it's like, you know, manna from heaven, you know, it's just like, hey, you know, it was there. Maybe it's for a purpose.
The money is certainly there. You know, to your point about, you know, the healthcare system, you know, those of us on the front lines, every single solitary day, we see the damage being done by this, the most expensive healthcare system in the world, how it is harming people, you know, and I think that we can make the changes. I mean, 10 years ago or so, I'm not good on the dates, but would we ever have thought that same-sex marriage would be the law of the land? No, we never would have thought that, and yet it did. And so we really believe, you know, in both the Democratic National Committee and in the Massachusetts Democratic platform, both of them have single payer planks, Medicare for all, and yet session after session they ignore it and ignore it. You know, and one thing that I did feel during this Steward crisis is that I really felt like the politicians would suffer no consequences with the closure of these institutions. There will be no political consequences. So they really just kind of had to ride it out. So I really do believe that if we put our minds to it and all of us worked on it, I mean, Senator Eldridge files the Medicare for All legislation every single session, it doesn't go anywhere. We support it. It is broadly supported. I do believe, I think that we have the best minds, some of the most experienced activists in this community, in this state, and I think that we could make it happen should we all put our weight behind it.
So we have about 10 minutes before we wrap up. So I wanted to bring up one other point, which, you know, just so we don't forget this, which is the dislocation for thousands and thousands of workers in the Steward system. Yes, both unions, I believe, have strong successor language, which means that their contracts stay in effect for a new buyer. But, you know, some of them are entering non-union systems, different sets of benefits. Obviously, for the people at Kearney and Neshoba, the whole issue of their, you know, there's, you know, PTO and severance pay. I mean, these are some really significant, you know, these are a lot of workers, 16,000 workers who have dedicated their lives to a system. And, you know, have, you know, in some way, some people went from Kearney to Quincy, back to Kearney. You know, people have really, you know, hung in there through COVID. So I just think it's really important for us to recognize that it's not just the communities that are losing healthcare, but 16,000 people and their families, regardless of whether they're still at St. E's or they're at Kearney or Neshoba. It's a huge dislocation. It's loss of jobs in our communities, loss of services, and the ripple effect. I was told the other night that, BI, gastro and, gastro folks actually do use the ORs at times at Kearney, and the shutting of those ERs, the operating rooms at Kearney means that colonoscopies are backed up, life-saving, important scanning procedures. Just, now people will wait way, way longer. So we know we have a crisis here. So what I wanted to do is, and I feel like there were so many ideas brought up here. A lot of them go into the important thing that we need really meaningful healthcare planning in Massachusetts. We really need a different way of looking at the, for lack of better term, market, but I mean more the healthcare environment as opposed to market. And the fact that we need, some form of, real reform that looks at this whole issue of receivership and, hospitals as really essential, community providers and not just businesses, et cetera, et cetera. And I think there's lots of food for thought in terms of, for future political action. I also think, Alan and others spoke to the dysfunction that exists in the legislature and how difficult it is to move things, which I believe is a big question facing, many organizations in Massachusetts that are looking at how can we do things differently. But I wanted to give everybody like a minute or two to wrap up, because we said this forum would last till 8:30. We will be sending out the recording, and we will also send out, if there's a particular set of actions that we want people to take, we can also send it out. So I'm going to just, whoever wants to go first, and I am going to time here because we said 8:30. So I'm going to give everybody about 90 seconds if they can do that. So anybody want to start? Katie, you want to start? Because I know you have a particular ask.
You know what, I think, I think I did touch on it, about the bills that we file. And, it's about transparency. It's about the closing of essential services, putting real teeth in the legislature. And, again, I just said it and I don't want to repeat it, but we're going to be filing all of these bills again in January. It's a laborious slog through the 2-year session or the 18-month session. But I think if we get behind it and we can get some real teeth into our regulation in this state, that is the way to go.
Mm-hmm. Okay, and that includes Medicare for all or single payer,
Oh,
correct?
yes,
Okay.
absolutely. I think that, that's the first thing that we see, that we believe that everybody should have that wraparound care, access. And so that's what's involved in Medicare for all. If you have it, that people can have access to health care where and when they need it in a culturally competent set of circumstances. For instance, like the Kearney, Medicare for all is the answer, and it saves tens of millions of dollars, which I know Kimberly can talk about more. But yeah, we do believe, start with the patient and take it from there.
Okay, who wants to go next?
I'll go. I'll build my comment off of Bill, who said a few minutes ago that we really need to think about the whole healthcare system as not just a sort of a free fall open market, but really how do you meet people's needs? And we know that since the market doesn't tend to function, we need government to sort of assert itself in different ways as needed. And, and maybe philosophically, our legislature, our government oversight apparatus can sort of see that this is not the time for laissez-faire, but really a time for, in some ways, more government oversight to address some of the, the issues that we started with here of redistributing between the have and have-nots. And it isn't just to redistribute it to providers, but it's to redistribute so that communities often served by the have-nots get what they need. So,
okay. Bill, Alan, Bill.
Okay. So I'm just gonna, end up by just saying, for the purposes of the Kearney Hospital, we need to, either the state or the city needs to seize the land as quickly as possible, make a deal, or if you seize the land, one or the other, so that the property can be utilized in a way that the community wants it to be utilized. I think that the community health centers are ready and willing to, to get together to start looking at, could they provide 7 days a week of urgent care? And that could happen out of the ambulatory care center at the Kearney. The emergency room they should prevail upon BMC or Beth Israel to say, hey, look, we're the state and somebody should reopen that emergency room as soon as possible. People will die on that. And I've talked to numerous people who have told me that they would have died if the Kearney Hospital emergency room wasn't there. The psychiatric beds need to go into the Department of Mental Health. And we need to start looking at, creating a group of people that will take a look at what else is needed in our broader community that the Kearney Hospital could be used for in the near future.
Addiction treatment.
Okay, Alan?
Two things. If we passed single payer tonight, we'd still have the morning after question of how to make the relationship work. Because let's say we get rid of the for-profits, all the hospitals are nonprofit. They still have to be run in the public interest. And a lot of them are not being run that way today. So it's a question of governance. And also, if we want to pass new laws, let's please recall that state government 12 years later has refused to do its job and enforce Chapter 224, which requires health planning. So to call for health planning from a state that hasn't done it and doesn't want to do it, I think what we have to do is prepare for the time the money runs out. And when healthcare faces a crisis, it'll be willing to change, and we have to have ideas and draft legislation in place and working with doctors and hospitals and others to be ready, because right now, unfortunately, despite our good ideas, the opportunity politically is not there.
Well, thank you, everybody. And I think Alan's point about the political opportunity and the challenge of working in the legislature. I know a couple of people posted in the chat, could we do a ballot question? Well, having worked on a number of successful ballot questions in Massachusetts, including Fair Share, it's a very long, cumbersome process where you need a lot of money, a lot of organization, and you still have to work with the legislature to actually get it on the ballot. So it's a multi-tiered process, but I think there's a lot of food for thought here. And I think both Progressive Mass and Mass Care can take some of these ideas and figure out how can we, determine how we can be supportive to some of these campaigns and thoughts. And, we will be sending out a recording of this and at least, some potential next steps. So I'd like to thank our panelists, for being part of this. And hopefully, maybe a couple of months from now, we can come back and sort of say what happened with Kearney, what happened with Neshoba, because as we know, this is not an issue that's going to go away tomorrow. And, I think all of us are also concerned, ultimately about what is going to be the state's responsibility and how effectively will the governor, oversee what, and how will these transitions in terms of, what the new ownership of each of these systems are, will be. And the ownership of the, lifespan is not even in our state. So that's a whole other thing. So I feel like none of these are very simple solutions. And yes, healthcare may be preserved in some areas, but the question will be, what will it look like a year or 2 years from now? So thank you, everybody, for being part of this. And I hope to our audience, I did try to incorporate a number of the questions from the chat. I hope that our audience actually, found this to be a useful discussion and hopefully one that's an ongoing one. So thank you, everybody, for being part of this conversation.